in muscular disorders. وطبعا دكتورة منى حاتم my friend and a very passionate partner في الجامعة فمتحمسة قوي فأنا I will definitely support you في كل حاجة يعني. Best wishes دكتورة.
Good morning everybody. My talk today will be about the evolving role of PET-CT in muscular disorders. As we all know, diffuse whole body muscle uptake in PET-CT can be caused by insulin intake, recent food intake, and strenuous exercise. Anxiety also and restless movement can do this to the scan. This is the whole muscular uptake. As you can see, it is bilateral, symmetrical, including all body muscles like the paravertebral muscles also. But what if this is not the case? Recently, a spectrum of muscular disorders were addressed clinically, and PET-CT has contributed to their diagnosis and management. For example, dermatomyositis and polymyositis is a systemic inflammatory disease with an unknown etiology and prognosis that can cause muscle weakness and characteristic skin rash, and also affecting internal organs like lungs and the heart. The mortality rate is approximately three times greater than the general that of the general population. The 5-year survival rate is 60 to 63%. Almost 20 to 25% of the patients have malignant tumors. Yet, dermatomyositis without malignant tumors is the most common form, accounting for approximately 75% of all cases. And although invasive, the gold standard in the diagnosis is muscle biopsy. However, because there is patchy distribution of the muscle lesions, the biopsy may not be conclusive. And also, although serum creatine kinase level is a major clinical biomarker in polymyositis and dermatomyositis, it does not always reliably reflect the disease activity. PET-CT can screen the whole body in one scan, evaluating the extent of muscle lesions systemically at one time. Also, the visual and SUV parameters are useful in discriminating polymyositis and dermatomyositis from non-muscular diseases, as well as showing correlation with serum muscle enzymes. In this case, this is a normal PET-CT with regular or normal physiologic muscle uptake. In this case of dermatomyositis, the FDG uptake is almost bilateral symmetrical, including the shoulder and the arm muscles, the proximal arm muscles, as well as the proximal thigh muscles. However, as it is well known that FDG uptake in muscles is influenced by hyperglycemia and uptake by other organs, also by voluntary and involuntary muscle movement, therefore the examination must be conducted under strict conditions. These PET-CT images demonstrate multiple hypermetabolic mediastinal lymph nodes and bone lesions in a patient known with lung cancer. There is also a slight increased cutaneous FDG uptake in the right lumbar region. And when cutaneous biopsy was done, it confirmed the diagnosis of dermatomyositis. This is another case where PET-CT is used in screening of polymyositis and dermatomyositis to detect the occult malignancy. This is a case where there is a left upper lung mass with metastatic left supraclavicular and left hilar lymph node and metastatic splenic focal lesion in a case of dermatomyositis. So it is necessary to screen malignant tumors before start of treatment to identify risk factors of poor prognosis which affect the treatment strategies and to improve the survival rate. For patients with malignant tumors, anti-tumor therapy should be considered first, and their prognosis and life expectancy should be determined by the underlying malignant tumors rather than by dermatomyositis. And for patients with dermatomyositis without malignant tumors, an MDT approach is recommended. It is widely known that pulmonary involvement is a common cause of mortality, with the most common manifestation being interstitial lung disease, affecting 10 to 15% of patients. It has been recognized as a predictive parameter of poor prognosis. PET-CT can help in the assessment of activity of the interstitial lung disease, like in this case, where there is an increased uptake in certain parts of the lung. This is another case of PET-CT showing heterogeneously increased muscular FDG uptake with multiple hypermetabolic lymph nodes and hypermetabolic spleen in a patient with dermatomyositis. And the arrows here, they show some pulmonary nodules with low FDG or inappreciable FDG avidity, indicating that there is an interstitial lung disease but not in an active stage. Moreover, cardiac involvement occurs in up to 70% of patients with idiopathic inflammatory myopathy, and it can be lethal. As a one-stop shop method, PET-CT is valuable for measuring the indicators of cardiovascular risk, including the epicardial fat volume and coronary artery calcium. The epicardial adipose tissue is a fat reservoir located between the myocardium and the pericardial visceral layer, and it is a source of cardiac inflammation induced as a new imaging risk marker. Cardiac involvement is considered one of the 3 major causes of death in dermatomyositis other than interstitial lung disease and malignant tumors. At autopsy, subclinical myocardial inflammation is common and occurs in about 1/3 of dermatomyositis patients. This is a 43-year-old woman followed up for 95 months, and she had low pulmonary SUV max and low epicardial fat volume. Another case for a woman who died shortly after 22 months within diagnosis, and she had pulmonary high SUV and low epicardial fat volume. Another male who died within 18 months of diagnosis, he had low pulmonary SUV but high epicardial fat volume. This is a 64-year-old man who died within 13 months. He had both high pulmonary SUV and high epicardial fat volume. So therefore, it was found that the high epicardial fat volume and also the pulmonary SUV max affected the survival rate of patients without malignant tumors. This is a case, the only case that came in Demirdash, in our PET-CT unit. She had she was diagnosed with dermatomyositis and came to search for any hidden malignancy. Fortunately, she did not have any malignancy. She only had a dermoid cyst with a calcific focus, and she had symmetrical, diffuse, low FDG uptake along all her muscles, along her body. No activity, no sign of activity, so she was a lucky patient, but she was the only one who came to our unit, so I decided to include it in this presentation. Now we'll come to polymyalgia rheumatica. It's the most common inflammatory rheumatic disease in patients over 50 years of age. It's more common in women than men. It affects bursae, synovial joints and tendons, and characterized by pain and stiffness in shoulders and proximal parts of the arms and proximal parts of the thigh and hips. This is an 82-year-old woman with significant uptake around the glenohumeral joint, the sternoclavicular, the hip joint, as well as the ischial joint. And this is suggestive of diffuse osteoarticular pathology with an inflammatory component in the context of PMR. Approximately 50% with patients with giant cell arthritis present with the clinical symptoms of PMR. Patients with PMR who present with giant cell arthritis range from 5 to 30%. Usually, an appropriate clinical assessment and the routine inflammatory lab markers can help establish a diagnosis of PMR. However, PET-CT may be useful to establish a comprehensive evaluation. PET-CT can be helpful in disclosing vascular involvement since it can visualize almost all arteries, including the deep vessels. Studies showed that patients with isolated PMR had increased vascular FDG uptake predominantly in the subclavian arteries. Giant cell arthritis may initially manifest as PMR. PET-CT can reveal the large vessel vasculitis in at least 1/3 of the patients initially diagnosed with isolated PMR. Here, PET-CT can identify the extracranial pattern of giant cell arthritis. This is a case, there is an uptake around the glenohumeral joint, but also an increased uptake around the aorto-iliac bifurcation that correspond to vasculitis in this case. Another case showing increased FDG along the glenohumeral and the hip joints, but also around the subclavian arteries bilaterally, denoting large vessel vasculitis. Also uptake here in this case, there is an FDG uptake around the glenohumeral joints, the hip joints, here another uptake around the subclavian and axillary arteries bilaterally, consistent with PMR and giant cell arthritis. So when do we have to perform the FDG PET-CT in PMR? Actually, there's no need for PET-CT in typical cases because of its high cost and unavailability. We only consider PET-CT in patients with atypical features when there is a lack of elevated lab markers or when there is a history of cancer. Cancer patients often present with atypical features like lack of morning stiffness, more widespread pain, not only located in shoulder and hip joints, and when there is a poor response to glucocorticoids. However, there are also situations where a patient previously treated for cancer may genuinely have PMR. It is crucial to rule out cancer relapse and accurately diagnose new onset PMR using PET-CT. This is a case of an 82-year-old woman previously treated with breast cancer and currently diagnosed with PMR because she had bilateral increased uptake around the glenohumeral joint and also around the sternoclav and in both hip joints. Another case, the opposite. This is a known case of PMR, and now she's presented with multiple hypermetabolic mediastinal lymph nodes, and the patient was finally diagnosed with a lymphoproliferative disease. It is also interesting to remark that the immune checkpoint inhibitors used in cancer patients can cause the appearance of a wide spectrum of musculoskeletal symptoms, sometimes indistinguishable from primary PMR. It's a PMR-like syndrome. PET may be useful to discriminate between the primary PMR and those associated with the immune checkpoint inhibitors. What about glucocorticoids? They are used prior to PET-CT. When they are used prior to PET-CT, it may reduce its sensitivity. It's a treatment in PMR. So FDG uptake is reduced in patients with large vessels, giant cell arthritis, after only 72 hours of treatment with high doses of glucocorticoids. So some experts advise to discontinue the glucocorticoids prior to PET-CT just to improve the diagnostic accuracy. The limitations of PET-CT in PMR, there are inconclusive results indicating challenges in its utility for long-term management. Current guidelines do not universally recommend its use for all patients with PMR, especially in absence of atypical symptoms or refractory disease. Also, its cost and inaccessibility and exposure to ionizing radiation are one of the limitations. It is also sensitive to inflammation, but not specific to PMR. There are inconclusive results indicating the challenges in its utility for long-term management. The current guidelines do not universally recommend its use for all patients with PMR, especially in absence of atypical symptoms or refractory disease. The take-home messages is that take-home message in dermatomyositis and polymyositis, it is mainly used to exclude and diagnose malignancy in patients with inflammatory myopathies. It may also be useful in evaluating disease extent, to identify the site of biopsy and to exclude interstitial lung disease and cardiac involvement. In PMR, PET-CT can be a very useful tool, not only to help diagnosis, but to identify the associated disease, such as the giant cell arthritis and the malignant process. However, the best moment to perform this technique remains to be undefined. Thank you.
محاضرة جميلة جدا جدا يا دكتورة
ميرسي يا
منى،
دكتورة
واستمتعت بيها جدا.
الله
ولو
يخليك
تسمحوا لي بقى مش بسؤال واحد بكذا سؤال.
اتفضلي
حتتي
حضرتك.
ويعني أنا فعلا مبسوطة جدا وجاية النهاردة عشان المحاضرة
انا
بتاعتك
عامله
ميري.
مخصوص المحاضره عشان حضرتك
ربنا
والله.
يخليكي. دلوقتي احنا عندنا الحقيقه يعني روماتيك ديس اوردرز ما بيبقاش سهل قوي التشخيص والاسسمنت والبروجنوزز، لان زي ما انتم عارفين مش سنجل بلاد تيست بيخلينا نشخص. حالات الدرماتومايوسايتس والمايوسايتس والانكلوجن بودي مايوسايتس بنشك فيهم، بنعمل الاي ام جي مش دايما بيبقى كونكلوسيف، بنعمل السي بي كي انت عارفه في حاجات كتير قوي بتعليه، فبنلجا للام ار اي. رايك الام ار اي ولا البات سكان؟ لان يعني عاوزه اشوف ان هو التول اللي تبقى اسهل لي وارخص لي وتبقى مور كوست افكتيف بالنسبه للعيان بتاعي.
والله حضرتك احنا الاكسبيرينس بتاعتنا لسه في الموضوع ده يعني ليميتد قوي، بس احنا لاحظنا ان ابتدى يجي لنا فعلا عيانين دول بس فور سيرشنج اوف هيدن، يعني فور هيدن مالجنسي،
لكن مش للدايجنوزس
بالظبط.
يعني
لدرجه ان احنا في الاول اصلا كنا بنأجل العيانين دول، لان فعلا زي ما قلت كده في الاول الابتيك الديفيوز ده كان بيخلينا نفتكر ان في مشكله في التحضير بتاعنا، كنا نأجل العيانين وبعدين نرجع نصورهم تاني نلاقي في نفس المانيفستيشن، فابتدينا نفهم ان في انتيتي اسمها درماتومايسايتس واخده
كل الماسلز
ديفيوز ابتيك، بس احنا لسه ما جالناش حد خالص علشان تو دايجنوز. يعني احنا حقيقي مينلي كنا بندايجنوز هيدن مالجنسي، وحصل قبل كده فعلا وي دايجنوزد حاله كان فيها بريست كانسر وما كانش باين خالص، كانت حاله درماتومايسايتس دي جات لنا من سنتين. هم ما بيجوش كتير بس انا لقيت انها فرصه ان احنا نبتدي يعني
طيب. يعني مثلا في يعني الدرماتومايسايتس بيبقى عندنا perivesicular inflammation، المايوسايتس والانكلوجن بودي والليكوتايزنج مايوباثيز بيبقوا فيهم انترا فاسيكولار انفلاميشن. ده بيبان
لا
في حاجه من
التفاصيل
دول
دي مش هتبان للاسف في البات سي تي. السي تي كومبوننت اصلا هو اللي بيوري الماسل، يعني لو هيبقى فيه انفلتريشن مش هتبان الديتيلز دي، الديتيلز دي هتبان اكتر في الام ار. فحضرتك الام ار هو تيشو كاركترايزيشن مينلي، يعني كونسيرن بالموضوع ده، لكن البات هيوري الاكتيفيتي، الديزيز ده اكتيف اور نوت. هيساعد فعلا لو هنعمل سكين بايوبسي، هيساعد البيست سايت فور بايوبسي. لكن يعني حضرتك عايزه تشوفي ديتيلز بقى يبقى الام ار هو هيبقى مور.
معلش سؤال تاني عشان ده انا بيحيرني في الشغل، واسف على الوقت كتير
اللي
خدته.
ازاي حضرتك؟
بس فرصه يعني لقيتكم كلكم كده فاسال. اللارج فيسل فاسكولايتس من الحاجات اللي بتتعبنا جدا، وذر جاينت سيل ارثرايتس او تكيسه. بنعمل كات سكان انجيو. مش المشكله بقى في الدايجنوزز الاولاني لما يجي لك عيان كان متشخص ويرجعوا يقولوا لك ده كده ولا لا، ويكون خد ستيرويدز، فبالتالي بيكون العيان مش اكيوت. بعمل كات سكان انجيو بلاقي ناروينج. هل البات سكان ممكن يساعدني بحاجه اكتر؟
لازم هنوقف التريتمنت عشان اقدر اشوف
الديزيز. ما هو ممكن يكون دخل في ان اكتيفيتي، فهل هقدر
مش هيوري
يعني هي مثلا هيبين لي ناروينج، هيبين لي
هيوري في السي تي كومبوننت، ولازم ساعتها يبقى الحقن فعلا حقن سي تي انجيو عشان برضه هيدي نفس الديتيلز. يبقى ساعتها يبقى ويست اوف ماني اند تايم ان انا ادي ماده مشعه على حاجه كان برضه السي تي انجيو هيبينها من الاول.
يعني السي تي انجيو هيدي نفس الديتيلز بالنسبه للفاسكوليتيز ان جنرال whether اكتف او لا، وذر في ناروينج او
بالظبط الناروينج
بوستينوتيك
دايلاتيشن والحاجات دي كلها يعني كونسيرن بالسي تي انجيو.
احنا عايزين مره تعملوا لنا محاضره على الشغل بتاعنا ونسال براحتنا، عشان انا مكسوفه اسال